Good afternoon. I'm Margaret Gray. For those of you who don't know me, I'm Dean of the Yale School of Nursing, and it is indeed my pleasure to welcome you this afternoon as we celebrate a very important YSN tradition, the annual Bellos Lecture. It is always wonderful to welcome back old friends and see some new faces with us during this lecture period. At this time, I would like to ask that you turn off all of your cell phones and pagers or set them to vibrate. If you need to answer the phone, please leave the room and answer the phone outside. Each year since 1994, we have used this opportunity to honor the memory of Mrs. Bellos, a public health nurse, by recognizing a student who has made outstanding contributions to the New Haven community in the delivery of health care or in volunteering their time to outreach efforts. YSN students become leaders in nursing by excelling in their studies and in their clinical work, and their leadership skills are further honed through their involvement in the community. Over the years, our students have helped develop and have taken part in numerous area outreach programs that have enriched the lives of individuals and families in the greater New Haven area. The 2013 Community Service Award recipient has contributed a great deal to the University and New Haven communities. She has made providing quality care to underserved women a focus of her time here. Her clinical skills and dedication to provide excellent, culturally sensitive patient care are truly impressive. She approaches her work with a mature, professional demeanor that puts at ease patients, staff, and colleagues. She has a strong grasp of didactic material, which she employs readily in assessing and managing patients. Her commitment to caring for underserved populations is clear and was demonstrated in the way she approached and responded to patients from diverse backgrounds experiencing a large spectrum of health conditions. In particular, she saw a need among patients at the student-run Haven Free Clinic and seized the opportunity to develop and expand the operations of the women's health area to serve not only patients, but also to educate the student staff of medical, physician's assistant, and nursing students on how to better serve patients presenting with women's health issues. She served as the Women's Health Coordinator and was named Director of the Women's Health Department. In that role, she molded a brand new department into a resource for patients and for her peers. She is dedicated to Haven and is responsible for invigorating and expanding the women's health area to feature health educators that counsel patients on contraception and abnormal test results in order to improve the quality of reproductive health care at the clinic. To accomplish her vision, she trained and coached a team of 11 health professional school volunteers in contraception, pap testing, and intimate partner violence. She created a domestic violence panel as a response to the increase in reporting of intimate partner violence among her patients and developed clinic guidelines so that patients could more effectively be triaged and receive IUDs. She has advocated strongly for women's health services in Haven at all leadership and community meetings. She has recruited YSN faculty to serve as preceptors and has been instrumental in increasing YSN student participation. She takes personal responsibility for the most sensitive cases with compassion and commitment. Her colleagues particularly note her availability to other students to provide consultation on contraceptive education for patients. She builds bridges, collaborating and problem-solving through interdisciplinary teams of clinical advisors, students, and organizations, all with the goal of better and speedier follow-up and healthcare delivery to the Haven Clinic's often complex patient. Doesn't that fit well with today's speaker? One of her nominees made the following statement: "She is an outstanding student and colleague and has contributed much to the New Haven community. She is trustworthy, passionate, and driven to help women marginalized by poverty, limited access to services, and psychosocial barriers. For her compassion, deep commitment, and significant contributions to her community, the Yale University School of Nursing is proud to present the 2013 Community Service Award to Sarah Gilbert.
This is a copy of the citation. And you're welcome to
This is such an honor, and I really wanted to thank the people who nominated me for this award. I know these things take lots of time, and we're all so busy, but I really appreciate it, and I really appreciate the many people in the room who I've worked with at Haven, and I'm really proud of what we've all accomplished there. Thank you very much.
She just found out she gets to take those flowers home. So now on to the lecture. Some of you are already familiar with the background of this lecture, but it is a tradition to tell it again every year. The lecture was established in 1964 in honor of Sybil Palmer Bellos, a 1927 graduate of YSN, on the occasion of her retirement as the director of the Northern Westchester District Nursing Association. Mrs. Bellos was known for qualities apparent from the beginning of her nursing career: dedication, vision, and a sense of adventure. A woman of great personal charm, modest and gentle, Mrs. Bellos was able to reach and touch others, and her influence had been felt far beyond her expectation. Each year, the executive committee of the school nominates a candidate to deliver the Bellos Lecture, a candidate whose work and reputation reflect qualities attributed to Mrs. Bellos, although I don't think of Suzanne as being gentle in her words. I think you will agree with me that today's lecture embodies many of those qualities. Suzanne Gordon is an award-winning journalist and author who writes about healthcare delivery, healthcare systems, and patient safety. Her 15 books include First Do Less Harm, Confronting Inconvenient Problems in Patient Safety. Her latest book is Beyond the Checklist: What Else Healthcare Can Learn from Aviation Safety and Teamwork. Ms. Gordon's book on healthcare have been published by the Culture and Politics of Healthcare work series at Cornell University Press, which she co-edits. She has been a radio commentator for CBS Radio and National Public Radio's Marketplace. Her articles have appeared in Harper's, The Atlantic, the New York Times Magazine, the Boston Globe, the New York Times, the Los Angeles Times, the Toronto Globe and Mail, and many others. Through her focus on teamwork in healthcare, she developed the concept of team intelligence and consults and trains on teamwork in healthcare all over the world. She is co-author of a play about team relationships in healthcare entitled Bedside Matters. The play has been performed at numerous venues, including the Institute for Healthcare Improvement, the Hospital of the University of Pennsylvania, Cedars-Sinai Medical Center, and is being used in interprofessional education programs in the U.S. and Canada, including the University of Toronto and the University of California, San Francisco. The play and accompanying workbook was published by Cornell University in the fall of 2012. Ms. Gordon has lectured all over the world on healthcare issues and has appeared frequently on radio and television. She is also a visiting professor at the University of Maryland School of Nursing and assistant adjunct professor at the University of California, San Francisco School of Nursing. She is also an affiliated scholar at the Wilson Center at the University of Toronto's Faculty of Medicine and the Center for Innovation in Interprofessional Education at UCSF. She is an editorial board member of the Journal of Interprofessional Care. She has been an articulate advocate for nursing and quality health care for a number of years. She is at work now on a new book on how to create and sustain team intelligence in healthcare with sociologist and interprofessional education expert Scott Reeves and with physician and former patient safety officer David Feldman. She is editing a book of team stories in healthcare. As Mrs. Bellos was concerned with the health of the public, and YSN's vision is better health for all people, I think you will agree that Ms. Gordon will serve as a great Bellows lecturer. With sincere gratitude for your work on behalf of nursing and quality healthcare, it is my pleasure to welcome you to Yale again as the 2013 Bellows lecturer.
Thank you so much. Do I need the mic or can you hear me? Can you hear me? Okay, because I kind of like to wander around. I'm really delighted to be here again, and I'm delighted to see people I've gotten to know over the years from Yale School of Nursing, aside from Margaret Gray, Judy Krause, my friend Marge Funk, and I'm really, really honored to be here, and very sad that Donna Deers couldn't be here and that I couldn't see her again, because I knew Donna for a long time, and I know that you're all mourning her. I would like to talk to you about the subject of my lecture today, which is team intelligence. And I am not a nurse. I'm not a doctor. I'm not a nurse. I'm not a pharmacist. I'm a journalist. And I've been writing about healthcare since the birth of my first daughter, when I discovered nursing. My father was a famous physician. He was a professor of ophthalmology at Cornell Medical School, and he practiced at New York Hospital. So I grew up sort of wandering the halls of New York Hospital, and I knew about doctors because we went to the doctor's dining room, but which I hope is still not there. But I'm not sure if they exist anymore in hospitals. But if we're really going to do interprofessional education and care, they should definitely no longer exist, because obviously socializing with your colleagues is really important, and if you're holed up in the doctor's dining room or the doctor's lounge or the nurse's lounge, you aren't going to be able to practice team intelligence. But in those days, and I'm 67, so they were a long time ago, I really didn't know anything about nursing. And then when I had my first daughter in a small community hospital outside of Boston, thinking that my friend, the doctor, who was in fact my OB, was a friend of mine, was kind of going to be there the whole time, because that's what I learned from Daddy, and that's what I learned on all the television shows, you know, where the doctors are lovingly at the patient's bedside 24 hours a day, and the nurses are too busy in exercise class or, you know, charting Dr. Love's doctors love lives to actually be at the bedside. And I discovered nursing, and I've been writing about nursing ever since. And often when I was writing one of my books or articles, my kids had to kind of, you know how we are, they had to deal with my preoccupations, and I apologized to them when I wrote a book called Nursing Against the Odds, and said that I hoped that my preoccupations with nursing didn't turn them off nursing. And I'm glad to say that one of them has become a nurse, which is great. But I come to you not as a nurse or a healthcare professional, but as someone who spent the last 27-ish years observing healthcare professionals, mostly nurses, in hospitals and other healthcare institutions, and looking at team relationships or the lack of team relationships. And as an early feminist and someone who was very concerned about gender issues and someone who sort of fought, when I was hired at United Press International in 1970, I was told by my boss or the person who was hiring me, that they had hired a woman once before, and if I didn't work out, they were going to never hire a woman again. And I thought, well, if if a guy doesn't work out, what do? Hire dogs? But we had to work in a very male-dominated system in journalism, and we struggled against that. And when I went into the hospital for the first time to observe nurses and doctors in the 80s, I was really stunned at the lack of team relationship and the lack of communication and the things that people put up with in healthcare that really people don't put up with in many other places, certainly not people who are professionals. And I began to write about nursing and to be very concerned, and over the course about these issues, and over the course of my, 26-year or 28-year, I can't really keep it straight, career writing about healthcare, I have seen some changes, but not enough changes. And it's very concerning to me because I define myself as an SP or a PP. I'm actually a graduate school dropout. So I don't have all these alphabet soup letters after my name. I just have a lonely BA, and I'm sometimes tempted to put SP or PP, which is sometime patient or potential patient. And so as an SP and a PP, and actually everyone in this room is an SP or a PP, right? Because we're all, unless we get hit by a truck, or die in our sleep, which is a death that most of us wish for and very few of us get, we're going to have contact with the healthcare system. And team relations and whether or not people relate to each other as genuine teams or as members and leaders of genuine teams is going to impact every single one of us in this room. Now, many of you are going to be impacted doubly because you're delivering care and then at some point you're going to get care. I'm only impacted singly because I'm just going to get it. And these issues of teamwork and communication are really critical issues. These are, whether you have team intelligence in action, if you have it in an envelope factory or Starbucks or, a hotel or whatever, it makes it, it's kind of nicer, right? It's nicer if you have genuine teamwork. In healthcare, it is a life or death issue. Whether people communicate with each other really, whether they listen to each other really, whether they solicit input really is a life and death issue. And we know that of the 100,000 people who die every year, and that's probably an underestimate, 100,000 deaths from medical errors and injury, and 1.5 million people are harmed, some of them seriously, from medical errors and injuries every year, right? More than 75% of those medical errors and injuries are the result of failures in teamwork and communication. It's not because people don't know what they're doing. It's not because they're stupid. It's not because they're incompetent. It's not because they lack technical proficiency. It's because they don't know, they don't have team intelligence. We're beginning to change that. Beginning, I think, being the operative term. And so I think these concepts and this issue is really critical. It's critical because I think healthcare suffers, like most of us, from multiple personality disorder. There's one, people say to me when these terrible things happen in hospitals and other healthcare institutions, they say, oh, well, they're not really serious about patient safety. People read my book, some of my books, like First to West Harm, they say they're not really serious about patient safety. And you can get so upset by what's going on in hospitals and other places that you can actually say that. I actually don't think that they're not serious. I think they have multiple personality disorder. And so as institutions, there's one of their personalities that's deeply serious about patient safety. But then there's another personality that is deeply serious about saving money and that thinks that you can do it at the cost of patient safety. And these personalities sometimes, kind of like Sybil. Has anybody read Sybil? So these personalities sometimes aren't even aware that there's this other personality over there, and sometimes they are aware. Sometimes the patient safety personality is aware about the cost-cutting personality. I don't know, cost-cutting personality may not be aware. Who knows who's aware of who? But I think that our healthcare institutions have this kind of multiple personality disorder, and the cure for that is to get team intelligence spread everywhere. I've spent a lot of time studying the airline industry and wrote a book about how we can learn from the airline industry. And so a lot of the the things I'm going to talk about you today have been put into action in an industry a good 30 years ago that suffers from a lot of problems and has a lot of similarities to healthcare. So what I'd like to talk to you about is this idea of team intelligence. How many of you know about emotional intelligence? You heard about emotional intelligence? Emotional intelligence is kind of like a big thing in healthcare, right? Everybody's talking about emotional intelligence. And I think that's very useful, and we can debate whether you have to have emotional intelligence in order to have team intelligence, etc. I firmly believe that you can have emotional intelligence and not have team intelligence. And that we have to teach people how to function on teams. Being on a team doesn't come naturally. In fact, in our society, it's almost bred out of us, right? We are taught how to compete. If we had time, I could do a bunch of really fun exercises that would show you some of this in action, but we don't have time. I'm going to do a couple of things with you, but we are taught to compete. We're taught to love conflict, destructive conflict as opposed to constructive conflict. I mean, all you have to do is turn on the television after 9 o'clock at night. Well, now it's all these cop shows and so forth that run all the time. You just have to turn on the television and see what we're socialized into. So whether it's natural or it's not natural, and whether, there's this huge debate about are we collaborative, are we competitive, clearly in our culture, we are not taught and socialized how to work together. We are most often socialized how to work against each other, and certainly that's true in healthcare, but healthcare is not the only place where that happens. And so I think it's really critical for people to develop a concept of what I call team intelligence, and for that to be cultivated in healthcare professional schools, in the healthcare workplace, in every place where patient care is delivered. I think that when I talk about team intelligence, it's very tempting to say that you need to do this for patients, and you have to do it for patients. But I think you also have to do it, to the extent that you are healthcare professionals, you have to do it for each other. Because the kind of demoralization that results from people not working together well is bad enough in any other setting. It's destructive enough in any other setting to the people who work in that setting. But in healthcare, you guys are doing really hard work. Every single day, you're working with people who are suffering and dying. Unless they come in for a cold, and eventually that person who comes in for a cold, give them time and they'll be suffering and dying. So you're dealing with a burden of suffering and death. That's extraordinary. You guys who have been doing it for a while think it's ordinary, but it isn't. I was at a hospital visiting a friend of mine who's a chief nurse, and we were going down an elevator. And a guy got in with a gurney. And this is a major hospital, and the gurney was covered over with a plastic, dark plastic, and I kind of looked at it and had a kind of shake, and I thought, oh, maybe it's a dummy. And then I suddenly realized it's a dead person. I was in an elevator with a dead person. Now, that doesn't happen in ordinary life. At the Omni, where I'm staying, hopefully, I'm not going to get into an elevator with a dead person. This is a weird thing that you guys are involved in. And even though it's normalized and routinized, it takes its toll, which is why nurses, doctors, pharmacists, etc., have more stress, more depression, more suicide, and so forth. So yes, you have to do it for your patients, but I think you need to work well together for each other. And I think that anybody who thinks that you can give good patient care, if you have just had a conflict with someone, if you've just had a dust-up with someone, if you're, all stressed out because you've been working too late and too long and you're sleeping on the job, as it were, think again. Because we all get the same brain, right? You don't get a brain transplant when you graduate YSN. You get the same brain. And conflict and poor working relationships and lack of teamwork impact you. And the fact that you're supposed to behave like a professional and an adult, you know, if people really believe that myth, I don't know what planet they're on, but they're not on this one. Because I don't know very many adults who always act like adults and very many professionals who, under certain circumstances, act like professionals. So that's why we have to teach them. And we have to teach them in their schooling, and we have to teach them in their training, and we have to teach them in their apprenticeship, and we have to teach them throughout their career, which is what aviation has done and what we need to do. We have an opportunity with interprofessional education and interprofessional care. I don't think it's clear. I mean, there's a whole lot we have to do to make that dream into reality, right? We're at the beginning, and we have to, you know, the devil's in the details. So what I want to talk to you about is the detail of team intelligence in action. Okay, so I've never heard the word team bandied about as much as in healthcare, right? Everything's a team. There's this team and that team and teamwork and it takes a village and a team and all that kind of stuff. But often what you discover is that the team is really what I call a group of intimate strangers engaged in parallel play at the bedside. And the question for me, having sat in on a fair number of planning for interprofessional education and practice, is whether we're going to go beyond that definition or whether we're going to actually just have a bunch of people engaged in, you know, intimate parallel play at the bedside who are kind of nicer and kinder to each other, but who are not necessarily doing what IPE is supposed to do in IPE, all the IPs are supposed to do, which is to work with, to learn with, from, and about each other, right? That's the challenge, right? As opposed to people just being really nicer to each other as they serially, solely take care of the patient once again. I think that's something we have to be really careful about. But when we begin to talk about team intelligence, we have to know what a team is and what it isn't. I'd like to ask you, I want to try to inject a little bit of interactivity into this because I know that all of you who are, particularly your students, are so tired of getting PowerPointed to death, right, and lectured at to death. So I want to ask you to write down on a piece of paper, if you're, well, in any workplace that you work in any place in life that you're in, if you're a student, if you're in clinicals, if you're working, score the teamwork on your unit, workplace, wherever you are, from 1 to 10, 1 being the lowest and 10 being the highest. Just quickly write down a number. How's the teamwork in the place that you're working? 1 to 10. If everybody would do that, I'd appreciate it. Just take 2 seconds, literally. Write down a number. 1 to 10. You know, what you see most of the time, the routine, not the exception. The exception could be great teamwork, it could be terrible teamwork. What's the routine? Okay, so I'd like you to keep that number in mind as we go through this, because a team isn't just a bunch of people who happen to be, taking care of, Joan Smith at the same time serially. A team is a trained aggregate of persons who have rehearsed. Trained in this case means rehearsed. It means trained and rehearsed, with interactive roles, who share explicit purposes, goals, information, plans, protocols, and very importantly, feedback and correction mechanisms. Right, that's very important. So J. Richard Hackman is at Harvard, and if people are interested in teamwork, I would really recommend his work, groups, leading in groups, I think it's called. And he says that, and he has a great, on his website, has a great teamwork scoring tool, a teamwork survey tool, which is really worth using. And he talks about, he makes the distinction between real teams and teams in name only. And he says that teams have to have compelling direction, which they share, an enabling structure, that operate in a supportive organizational context. This is where we get to the multiple personality disorder problem. A supportive organizational context, because you can only work so well in your small group if you're battling against broader organizational imperatives, right? It operates within, and it has expert teamwork coaching. So coaching as opposed to disciplining, right? To just accomplish a task, getting a patient safely out of the hospital or something, you got to accomplish that, right? You have to produce the output, the correct output. But in the course of producing the output, quality patient care or whatever, people have to be producing the ability to work together interdependently in the future. So you're not working on a team if we are taking care of a patient and every time I see Margaret after we work on this patient, I feel ill because I just had a conflict with her or she with me. That is not a team, right? Because teamwork sets you up for working together well. In other words, we should have worked together well, and that is another building block in the edifice of our teamwork that sets us up to work even better in the future, right? In patient safety, this is absolutely critical, right? Because the point of patient safety in a high reliability organization is you want to prevent problems, but since we can never prevent everything, you want to be able to manage them and you want to be able to contain them, right, if you can't manage them. And also, the process through which the teamer works together should contribute to the growth and sense of well-being, the personal growth and sense of well-being of the people who work together. So when we work together well, we don't just feel that, we've gotten somebody out of the hospital in a better state than they came in. We feel good about ourselves as opposed to demoralized, right, about ourselves. So think about that. Supportive organizational context, coaching, as opposed to I'm going to write you up, I'm going to discipline you, I'm going to have a talk with you, right? Think about this in nursing education, think about this in your workplace, setting you up to work better interdependently in the future, feeling good about yourself. Look, revisit your number. Revisit the number that you wrote down. How many of you would change your number? How many of you would keep your number? In the context of this definition of teamwork. Something for people to think about. Would you change it? I mean, did you have how many of you had a high number? Pardon?
What time?
Oh, 10. How many of you had like a 8, 9, 10?
Agreed by group.
Yeah, now how many of you still keep that number given this definition? Good. So, but wouldn't it be good if everybody here had that high number and kept that high number, right? That's really important. So I define team intelligence as the active capacity of individual members of a team to learn, teach, communicate, reason, and think together, irrespective of position in any hierarchy, in the service of realizing shared goals and a shared mission. And so you have to have a shared mental model. You have to have shared language. You have to have shared assumptions, right? assumptions are critical. And understanding the dangers of assumptions is really, really important. And I'm gonna, yeah, let's do this. This is gonna be fun. So if you, I'm not gonna move everybody around, and so some of you may not be able to do this, but so I would like you, the people, those of you, maybe you, Margaret, could you go over there? I said I wouldn't move people around, but let's see, could you come up here? Sure. And those of you who miss out on this. So could you guys put your elbows on the table, your right elbows on the table, turn to a partner and put your right elbow on the table as if you were arm wrestling. You have to move in. So you touch it. You do it? All right. So put your elbows together as if you're arm wrestling. Close your eyes. Close your eyes. Okay, close. Everybody's eyes have to be closed. No peeking. Are you guys not doing this? Come on. Well, you can't do it with 3 people. You've got to do it. Okay, grab onto each other's hands like you're going to arm wrestle, okay? And so the goal of this exercise is to get the other person's arm down as many times as you can. Close your eyes. Without being worried about about anybody else's score. So the whole goal of the exercise is to get that arm down as many times as you can. Go. So essentially, some of you were, like this till the very end, but what you're really supposed to be doing is this. So think about this exercise. Think about this exercise. I said arm wrestle. And you kind of have to say that, right? You don't actually even have to say it, but I said arm wrestle, so everybody makes the assumption that we're going to arm wrestle to the death, right? Right? And some of you, I'm not naming names, there is a re-education program that we're doing for the next week after. We'll come around to you. I know who needs re-education. But, so the very frame, right, this is the whole point of framing. The very framing of this exercise as arm wrestling set people's mental model into competition. And the fact that we're in a teamwork lecture and that I said you should ignore anybody else's score didn't make it through to some people and only made it through to other people at a certain point, right? Because the frame is what's important. And this isn't a judging thing. This is just how we function, right? I mean, as studies of the brain are now showing, the human brain is a how do they put it in Thinking Fast and Slow? Is a machine to make false assumptions. It's a false assumption making machine, and we do that because the brain is taking in so much stuff that we have to make these snap judgments and decisions, and so we do that very easily. But we have to learn. That's why we do team training, right? We have to learn, and we develop team intelligence to think about our our tendency to jump to the wrong conclusion and to make erroneous assumptions. We do prejudge things, and we are prejudiced, and one of the reasons why we prejudge is because we have to function really quickly. And so teaching people about this is very important. We have to cross-monitor. I'm going to kind of run through this. One of the things that's central to team intelligence is a concept that was developed by a guy named Edwin Hutchins at, oh goodness, where is he? He's in California somewhere, University, one of the UCs. And he studied aviation. He wrote an amazing book called Cognition in the Wild, which I would recommend. Hutchins talks about something called distributed cognition. And it's worth me reading. So all divisions of labor, and healthcare is a division of labor, right? Whether physical or cognitive, require distributed cognition. Even a simple system of two men driving a spike with hammers requires some cognition on the part of each to coordinate his own activities with the other. When the labor that is distributed is cognitive labor, the system involves the distribution of two kinds of cognitive labor: the cognition to do the task and the cognition involved in coordinating the task. That's kind of the team intelligence part. And in healthcare, I would argue that we suffer from a lack of an understanding of distributed cognition because we have these toxic hierarchies in which people think that only the kind of elevated partner is cogniting, is cognitioning, is thinking, right? The mindful person, whereas other people are doing mindless work. And you see this all through healthcare, right? What I call toxic hierarchy. You see this toxic hierarchy, the attending, the resident, the chief resident, the resident, the intern, the med student, the nurse, the nurse, the nursing student, the CNA, whatever, the advanced practice nurse versus the regular nurse, everybody thinking they're the ones who critically think and make decisions, and everybody else is somehow a mindless idiot. And our language even needs complete revamping, right? I shouldn't say this. Here at Yale School of Nursing, I've always hated the term advanced practice nurse. I think that's a horrible term because the opposite of advanced is retarded, inferior. And so how is it that, somebody who was a student of music can graduate from Yale School of Nursing, you can shoot me afterwards, and be considered to be advanced when a nurse who's been on the floor for 30 years is what? Retarded? I mean, these are bad words. They're hierarchical words that I don't think help describe anything and are not particularly useful for teamwork. I criticize often the term nursing as patient advocate because docs say, what does that make me, patient's enemy? And so we need to really rethink a lot of stuff if we're going to really have team intelligence. And some of these things are very cherished, right? Deeply held views. And I think we have to be willing to put everything on the table, right? Autonomous practice. Do we really want autonomous practitioners? I mean, wasn't that what got us in here in the first place, is medicine's autonomy? So there's lots of things that we have to be willing to think about. In terms of patients, the compliant patient orders, horrible term, right? For us as patients, right? We didn't follow the orders and we failed the therapy, and therefore it's okay if we die because we deserved it or whatever. The other concept, and all these terms play into this, because you can't have teamwork if you don't have this, psychological safety. This is a concept that Shine and Venice developed a long time ago, and Amy Edmondson at Harvard Business School has written a lot about this. And psychological safety is absolutely critical. If you have all these invidious distinctions going on, and all this kind of parallel play and everything, Are you going to have people who feel, if you have one group characterized as mindless, another group characterized as mindful, etc., are you going to feel safe to say to somebody at your own level or certainly above you, you didn't wash your hands, you're cutting off the wrong leg, you're giving the wrong dose. I noticed that the patient, I'm a housekeeper, and I noticed the patient is acting a little weird. I don't know. If you discipline people and write them up, etc., are they going to say, something? And the people in this room who are both educators and are being educated, you are going out there to be leaders, and one of the most important things you can do is think about how you practice. You have this huge opportunity to either to change things or to reinforce this toxic status quo, which I think in healthcare, toxic hierarchy, I think of it as the gift that keeps on giving. And you can interrupt that cycle by how you relate to people, right? Whether if somebody says something to you, do you and points up a problem, do you say thank you or do you, when you have a DNP after your name, you can come, even the word doctor, right? In patient safety, we now know that it's very important to flatten hierarchies, right? So in the OR or anywhere, you actually don't want people to call people doctor and then to call it's not Dr. Krause, I'm Suzanne or Susie and she's Dr. Krause, because I'm much less liable to tell Dr. Krause that she's about to cut off the wrong leg than I am to tell Judy she's about to cut off the wrong leg. We've learned this from aviation. So it's really important to think about how what we even call each other, right? And I know that I've sat in patient safety meetings where physicians will say to doctors, when you go in the OR, you should be all on a first name basis, and the doctor will say, oh no, my patient wants me to be called Dr. Smith, and I'm like, I'm sitting there being the final one, saying, basically your patient is unconscious, so I don't think your patient really cares. And if you told your patient that it was a patient safety issue, I don't think they would say, oh no, you must be Dr. Smith, you can't, So all of these things are really important because we have to thank people. We have to encourage people to question the status quo and to boat rock, and we have to really, really help people do that. I often walk into nurse managers' offices or CNO's offices or whatever, and I often see, I don't know if you've seen this, there's a little plaque that it says wine in a circle, W-H-I-N-E, with a slash in between. Those should all be thrown in the garbage can because people need to feel free to, quote unquote, complain. Now they need to be taught how to do it. They need to be taught how to do it, which is what team training does. But the notion of saying to people you shouldn't raise issues because that's whining is really a bad idea, right? Particularly if you haven't taught people the difference between a legitimate, constructive way to raise an issue and people who are accused of being whiners when they do. So these are some things that we need to think about. So here's my my little sort of effort to get a graphic designer I know to do a logo of Team Intelligence in Action. So the rim of the wheel is the team intelligence that we build, that we train people in. And I think that in IPE efforts in every health professional school, your curriculum should include actual team training, whether you use team steps or whatever, because working on cases together and all this kind of other stuff still doesn't necessarily develop the toolkit that you need to help people build teams, lead teams, be members of teams. I'm going to attack or address another problem I see in healthcare, and that is everybody wants to be a leader. Everything is about leadership. But one of the skills of being on a team, one of the skills of being in a team is leading a team. And another skill is being a member of a team. And if everybody's a leader and nobody's a member, then nobody's a leader, because you can't be a leader if you don't have followers. Like, I mean, you can be ahead of the curve, you can be a pioneer, you can be nuts, but you can't be a leader if there's nobody following you. And we need to teach people to be members, and we need to teach leaders when it's time to step down and be a member, right? And we need to teach members what they teach people in the aviation industry, which is inquiry, advocacy, and assertion, and precisely how to do that. Because that's a skill, right, that you can learn. So if you don't have team intelligence, then you get a very bumpy ride. Imagine being on a bike that looked like that, right? So I want to do a little exercise with you. And this is also a wonderful exercise to do if you're leading any kind of organization, behavioral change effort. I got it from a Russian engineer. It's TRIZ, it's in Russian. I have no idea what it stands for, and I can't remember what the English translation is. It's very huge. But basically, it's kind of like reverse thinking. So you want to deal with patient infections, reducing patient infections. You want to reduce patient falls. You want to reduce alarm fatigue. You want better teamwork. So rather than going and kind of lecturing people about all the things they're doing wrong, we do a TRIZ. So I want to ask you how you would have to behave in order to make sure, to guarantee that there was no communication and teamwork in your workplace, unit, school, etc. What behaviors would you have to put into play to absolutely guarantee that there would be no teamwork and communication in your institution, unit, workplace, etc., clinic? What would you have to do? You have to shout it out.
Ignore.
Ignore people? Okay, what else?
Don't talk to anybody.
Don't talk to anybody. Okay. So kind of be encased. And
No eye contact.
no eye contact.
Be little in public.
Be little in public. Okay.
Don't listen.
Don't listen.
Treat people differently based on position.
Oh, okay. Difference based on position. Okay. What else?
Destroy the infrastructure, like the policies and procedures, whether they're written or electronic.
Okay. What else? There's so much more we could do.
Eat alone.
Oh, eat alone, okay. Eat alone. Yes, or eat in your little disciplined group, right? Can I edit that to make it, nurses eat together, the pharmacists eat together, the docs? Okay.
Be unreliable in completing work.
Okay, unreliable. What about not introducing yourself to people, as in, she's the nurse, I'm the doctor, she's the patient, I walk in and just do my thing. No introductions, right? Right, how's that? Would that be good? What about yelling? How about yelling? Can you yell? Okay.
General rudeness.
Oh yeah, rudeness. Why didn't you get that done? Why don't I have my x-ray? etc. Okay.
Anger.
Pardon?
Anger.
Anger. Okay. We could add a whole lot of stuff to this list, but let me ask you how many of these things you see happening today. Do you see eating alone? Okay. How about ignoring people? How about unreliable people? And is unreliable people, is that a system problem or an individual problem? Oh, right. Don't talk to people, or don't talk to anyone. Do we see that? How about people who don't make eye contact? Do we see that? Yes? How about belittling people in public? Lots of that, right? Do we see it or not? Yes. How about don't listen? Yes. And you know what? As a corollary to don't listen, I think we should also add don't solicit. Because there's a lot, you know, with emotional intelligence and stuff, there's all this like active listening stuff. But that's not enough. You have to actually solicit, right? I mean, when a captain gets on an airplane, we don't see it, but when a captain gets on an airplane, they brief the first officer and the flight attendants. And they say to them, you know, there's going to be turbulence. They go through, like, what are we going to do? You know, there's a this happening, a that happening. And then they turn to them and they say, and do you have any concerns? Right? Because that's really the critical part, right? You can all pretend we're listening. Well, maybe some of us can't, but asking people if they have concerns, what are your concerns, right, is absolutely crucial. So, differences, treating people differently based on position. Do we see that? So, kind of like rudeness, etc. Right? Am I safe to say we see pretty much everything here? So, the question for all of us is, what on that list are you personally going to take and do differently? Because and this is kind of how you do a tris, you know, when you're doing this, when you're using this. It's a great technique to use when particularly when you have a bit more time, because what you say is, you know, what you can do is say, okay, so what are you specifically going to concretely do when, you know, to change this? Because a lot of this stuff here, aside from the organizational stuff, is stuff that we can change. It's part of the 15% of the things in our world that we can change, given the 85% that we can't. And I would argue that for those of us who are crazy enough to try to change the 85, it is gives us the energy to do that, because all of this stuff saps you. It really does. You know, it saps your energy and makes you, you know, not have the ability to do what you really need to do. I am going to skip ahead because I just want to say that what I've learned from my studies of the aviation industry, which has been really quite interesting to me, and I'm like the last person to have imagined that I would write a book with a commercial airline pilot. He's constantly he's always explaining to me how these things get off the ground, and I kind of like, you know, nod very politely, and I don't understand anything. But they have created a world in which they have gone from the not communicating mode to the communicating mode. And the reason why Sullenberger was able to land that plane in the Hudson, and I was going to show you a little video, but I really want to have time for questions.
Cactus 15.9, near departure to contact line, maintain 15,000.
Day 15,000, Cactus 1549.
After a series of avoidable crashes in the 1970s and 80s, commercial airlines finally got serious about passenger safety.
0.9, turn left lane 270.
This is Cactus 1539.
The airline industry developed a revolutionary new system of job training and information sharing called crew resource management. Pilots, flight attendants, and ground crews were all trained to share information and better collaborate on the job to dramatically reduce the risk of human error and radically increase the level of safety in this high-risk industry.
Can't do it.
Okay, which runway would you like at Teterboro?
We're going to be in the Hudson.
I'm sorry, say again, Cactus?
210, 4718. I don't know, I think he said he was going in the Hudson.
Lives were saved due to the combination of a very experienced, well-trained crew, all of whom acted in a remarkable display of teamwork, along with expert air traffic controllers, the orderly cooperation of our cool-headed passengers, and the quick and determined actions of the professional and volunteer first responders in New York City.
After 30 years of CRM training, air travel is now the safest it's ever been.
In the last 30 years, the airline accident rate has decreased at least tenfold.
How safe and reliable are other industries, like healthcare, where saving lives also requires teamwork and communication?
What occurred during my daughter's hospitalization in the pediatric intensive care unit was really a cascade of errors and miscommunication.
We harm millions of patients a year and probably kill 100,000 or so patients a year, maybe more than that, from medical mistakes.
So in many ways, we kind of continue blindly down this dark hallway or dark hole that set us up for both harm to my patient and, and put my practice at risk.
She spent 7 weeks in the pediatric intensive care unit with sepsis, a life-threatening infection, and left her permanently disabled for the remaining 19 months of her life.
Beyond the Checklist is a book that shows how the aviation safety model can be adapted to the healthcare industry.
Her resource management was a program that gave you a process and a language, and everyone knew that everyone knew the language. So if I said to you, Captain, I'm not comfortable with this, he had to hear that because it was done in a process in a way that we were all trained. It just meant that if you spoke up, they were going to listen. And it also meant you had a responsibility to speak up.
At first, they did not buy into it. I would say the majority of my colleagues in the 1980s thought this was just another fashion trend.
They refer to it as charm school.
The old way that healthcare was organized, with the doctor up here and everybody else down here, really created terribly unsafe conditions.
They come in, they see the patient, they do possibly order entry, and then they're off the floor before the bedside nurse even knows that they've come and gone.
All of the errors and miscommunication were just catastrophic in the way they affected my daughter.
So what does it mean to go beyond the checklist?
The aviation safety movement is not one thing like a checklist. That's why we call the book Beyond the Checklist, because it's about leadership, it's about followership, it's about anticipating threats and working together to figure out what you're going to do. It's about soliciting input. It's about encouraging people to speak up and supporting them when they do speak up. It's about teamwork training and communication training, and that's what needs to be done in healthcare.
Simple fixes like using a checklist or doing a double check, those help, but if you don't change the culture, if you don't change the nature of people's work, how doctors and nurses communicate with each other, how we train young residents and medical students, then you can't really, you can make some progress, but you can't completely fix this problem.
CRM can benefit the medical industry the same way it did the airline industry, in that lives are at stake in both industries.
First of all, there's too many patients getting harmed and there's too many gaps in communication. I can't wait for the system to change.
The problem is we don't have a lot of time because patients are dying every day. And patient advocates I work with, wonder, where is the outrage? How many more people are going to die before we're going to really change the system?
Beyond the Checklist is available at Amazon, or beyondthechecklist.com.
It's a video about CRM that's on my website, or our website about Beyond. If you go to Beyond the Checklist, www.beyond the Checklist. The reason why Sully Sullenberger, who was kind enough to write a forward for our book, was able to land that plane was because of 30 years of CRM training. And that was not divine intervention or a miracle or just the skill of one guy getting everybody off that plane without a serious injury or a fatality. It was teamwork. And it was years and years of practice in teamwork. And if we would do that in healthcare, and if we had the kind of psychological safety that they have in aviation, that they've worked very hard at, we would have it in healthcare too. I put her, Rosie the Riveter, up there because I actually live in Point Richmond, where the Kaiser shipyards were, and where the Rosie the Riveter Museum is. And I've gone to the museum several times, and it's a real inspiration because from night to morning, literally, in 1941, the government got women into the workforce. It got African Americans into the workforce. They created child care and health care in the shipyards and the munitions factory, because if you have women in the workforce, what do you have to have? You have to have child care. And if you've got to build all these things, you've got to have healthy workers. And they also got millions of people overnight to plant victory gardens. Overnight, because they had a huge sort of corporate public-private partnership to change the world. Now that was in a war, and I think what we have to learn to do is to help each other and to create teams, not when there's when somebody bombs the Boston Marathon or bombs Pearl Harbor. We have to do it, all the time. And I believe that we have an opportunity now with a focus on interprofessional education and practice. I think we have an opportunity because we have nursing schools like this one that is teaching people how to think smart, right? And I think that we can do it. But we just have to do it. And I thank you so much for having me, and I hope we can have a few questions and before we go to the wonderful reception.
The arm wrestling thing went way over my head. So was the goal to talk to each other and just see how many times you can do it?
So the goal of the exercise is really the goal of the exercise is to show the dangers of assumptions. Because if you don't clarify assumptions, you can't have teamwork. And it's also to show the power of framing. So that if we are in a competitive frame, we're going to go into competition and we aren't going to listen. Because what I said was, I stole this from the book Beyond Reason, which is the folks at the Harvard Project on Negotiation. And basically they do this exercise. And, you say people, arm wrestle, but then you have to be very careful to say the goal of this exercise, right, is to get your partner's arm down as many times as you can and not thinking about anybody else's score. So what happens is, it's the not thinking about the score, and it's the saying it's an exercise. You know what I mean? Does that make sense now? Or so some people. I've done this with people who before you just say put your arms down to arm wrestle, and they're already, they can stop listening. And then there's some people who get it like this, who go, the goal is to get your arm down. So I would say half the people in this room did this. I don't know, how many people, how did people work this out? Who worked it out and how did you work it out? Took you a while?
We just got it.
Okay, got it right away. Who took a little minute? Okay, so when you took a minute, how did you figure it out?
I don't know, Austin, it just clicked. Well, wait a minute, it's supposed to be about teamwork, so it's not about fighting each other. It's supposed to, we're working with each other, and then.
So the instinct is to do like this, and then you think about the frame. The frame, we're not thinking about teamwork. But some people ignored the frame. I mean, it's still. So the whole, I mean, these are just techniques that we can use to show the power of framing. So the social frame that we function in is individual practice and competition. And we want to change that. So it's useful to get to do some of these exercises just to kind of open people up to the change. What other questions? Yes.
I think one of the impairments, I totally believe in team intelligence, and it's so very important for productivity and for patient safety and all of these other things. But often, if you have a corporate stop in that, if it's not a corporate buy-in from every single aspect, then we can have as much team intelligence as we want. But if on the other side of the street, for whatever reason, whether it's the medical school or school of public health, if they're not part of the team intelligence, then that completely breaks the communication.
I couldn't agree with you more. And I just think we have to get enough team intelligence in ourselves and teach it and begin integrating these concepts into this opening that there is now. I mean, I was wondering whether to tell this story, but what the heck, I'll tell the story. I was at a major teaching hospital recently where they were doing IPE, and they were doing some simulation exercises. And it was for it was nurse midwives and obstetricians, and there were practicing nurse midwives and OBs, and there were students and residents. And there was a very interesting discussion about teamwork in the beginning of this, which was quite a useful discussion. And I'd been invited to sit in. And the nurse midwife said, well, really, if we were going to do teamwork, we would have rounds on the floor every morning with the OBs, and we would all say what our cases were, the midwives and so forth. Because now what happens in that place is that, the OBs come in when the patient gets into trouble. And they don't really discuss the cases. And I thought, what a great idea. Good idea, that's teamwork. And then the nurse midwife said, oh, but if we did that, we're supposed to be autonomous practitioners, and then that would mean that they would be intruding on our autonomy. And then I thought, oh, that's not so good, So I think that we all have to think about these, these things that are notions that we have that can, docs do this, nurses do this, we all have stakes. And so sometimes even the folks who think that they're, the great communicators and the great teamwork players, which is why I think they all need to be trained, right? Because, I may think I'm just the best, but, we're such bad judges of ourselves. And so we need people to help us kind of be the best that we could be. Any other? Thank you so much.
I think you were talking about us too, so thank you.
I was what?
You're talking about us and where we're going in our journey toward a new organization. And so we have lessons to learn, just in terms of how we as colleagues get along with each other. So, Suzanne, thank you. I'm delighted that you were with us. We have a tradition here that we mark every Bellos lecture with a poster.
Thank you so much.
And that's yours. You don't have to drag it home on the plane or train. We'll make sure we get it to you. But
Thank you.
I hope you'll remember
And
your
I'm
time
gonna
with
put it
us
up on my
fondly.
wall.
Great.
So, thank
Wonderful.
you.
So it's now my pleasure to invite you to attend the traditional reception following the Bellos lecture. This reception is a descendant of an annual tea given by YSN, the Wisser Tea. The background on Eleanor Wisser, who passed away while she was a student here at YSN, is quite lovely. Effie Taylor, who was dean at the time, wrote that Eleanor Wisser was admitted to the School of Nursing with a congenital cardiac condition. She was advised against attempting the course, but felt so keenly that it was something she had always wanted to do that she wished under any circumstances to be allowed to remain. Since this was her very earnest wish, we acceded to her request. Miss Wisser was very happy while she was with us and at no time regretted the decision that she made. We feel that her passing, which occurred in her sleep, was what she would have wished. Miss Wisser died on December 20th, 1937. Miss Wisser's will specified that every year at the tea, 24 talisman roses be provided from the income from the endowment. Those are talisman roses. And it was in 1994 that YSN added to this tradition by presenting the Wisser Tea's roses to the recipient of the annual Community Service Award. So they'll smell really nice in your apartments there. And please join me outside for the reception, and while you have an opportunity to share your thoughts and reactions to Suzanne's talk with her directly. And thank you for being with us today.